Welcome. I'm Dr. Len Calabrese from the R.J. Fazenmeyer Center for Clinical Immunology, and I'm welcoming you to another episode of Rheumatology Virtual Grand Rounds. These are cases that I bring some of the leading authorities in the country in the area of rheumatic and immunologic disease to work through a problem with you that I think will be worthwhile to your practice and make you more confident in dealing with this disease. And I couldn't think of anybody better to talk about spondylitis than Chris Richland. He is currently a professor of medicine at the University of Rochester Medical Center and has done a lot to enlighten us about spondyloarthropathy and psoriatic arthritis. So without any further ado, Chris, welcome.
This is Christopher Richland from the University of Rochester Medical Center in Rochester, New York, and I want to welcome you to the Virtual Grand Round series. I'm going to be discussing the diagnosis and management of complex ankylosing spondylitis. I'm showing my disclosures on this slide for consultancy and research. And the objectives of this presentation are outlined on this slide. The primary objectives are to discuss new data regarding the prevalence of inflammatory back pain in the United States based on population data. Second, we're going to be able to learn how to apply new criteria for spondyloarthritis that will facilitate identification of patients with early disease. Third, to better understand the major comorbidities in spondyloarthritis and how they can influence disease management. And fourth, describe management strategies for patients with ankylosing spondylitis that are refractory to anti-TNF agents. So I'm going to start with a case of a young woman with low back pain. A 26-year-old female presents with back pain of 3 years' duration. The pain is worse in the morning, associated with 2 hours of morning stiffness, and is relieved by exercise and non-steroidal anti-inflammatories. She also has significant fatigue because the back pain disturbs her sleep in the middle of the night. Recently, complaints of anterior non-exertional chest pain have been a predominant problem. She has no other complaints, however. Past medical history is unremarkable. She's Gravida 1, Para 1001. She works on an assembly line and smokes a pack of cigarettes per day. She's married with a 3-year-old child, and her husband is currently unemployed. Her mother has psoriasis, and her maternal aunt has Crohn's disease. It is becoming increasingly difficult for her to carry out her activities at work, and she is considering filing for disability. On examination, she's an anxious Caucasian female in no acute distress. The general examination was normal. The musculoskeletal examination showed no peripheral arthritis. She had a positive Patrick's test bilaterally, and Schober score was 14 centimeters with chest expansion of 2.5 centimeters with pain when she took a deep breath. She had moderate tenderness over the costochondral junctions. Radiographs of the spine, chest x-ray, and AP pelvis were normal. Specifically, she had no changes of erosions or pseudo-widening of the sacroiliac joints. C-reactive protein was elevated at 15, sedimentation rate slightly elevated at 25. An MRI of the sacroiliac joints revealed bone marrow edema on the sacral and iliac sides of the joint bilaterally. She had early erosions in the SI joints. The first question. A recent study from the Nurses' Health cohort, the NHANES cohort, demonstrated the range and prevalence of ankylosing spondylitis in the United States is approximately A, 0.1 to 0.4%, B, 0.5 to 0.8%, C, 0.9 to 1.4%, and D, 1.5 to 1.9%. The next slide provides the answer. According to the 2009-2010 NHANES survey, which looked at over 5,000 patients and used two sets of classification criteria, both the AMOR and the ESSG, the age-adjusted prevalence of ankylosing spondylitis ranged from 0.9 to 1.4%, and you can see the confidence intervals. Certainly these numbers are higher than some had previously predicted, but certainly this would indicate that there are a large number of patients in the U.S. population who are not being diagnosed with ankylosing spondylitis. Elements included in this survey are shown on this slide. So the elements from the AMOR criteria are shown on the left and from the ESSG criteria on the right. A quick perusal of this table will show that key questions that have been shown to be important in the diagnosis of inflammatory back pain were included. We will be going over some of these key inclusion criteria in a moment. Another important point recently presented in the literature was that familial but not sporadic ankylosing spondylitis is linked to HLA-B27. So in the cohort from Oxford of 502 patients and 391 first-degree relatives with ankylosing spondylitis, they found that AS was much more prevalent in familial compared to sporadic disease. And you can see the difference in the odds ratios and the significance. We also know that spondyloarthropathies have several common features, including association with class 1 MHC alleles, involvement of the axial spine, osteitis and enthesitis, and when peripheral arthritis is present, it is usually asymmetric. Extra-articular features, which we will also be discussing in the second half of this presentation, can include psoriasis, uveitis, and colitis. So inflammatory back pain can be approached using the ASAS criteria for diagnosis. And these are to be applied with patients who have chronic back pain of more than 3 months. And the inflammatory label can be applied in patients who have age of onset less than 40 years, an insidious onset, and improvement with exercise. Traditionally, these patients do not improve with rest and may actually worsen considerably, and they can have pain at night with improvement upon getting up. And if you recall our case, this woman had severe pain in the middle of the night that was really disturbing her sleep. So it's considered to be consistent with inflammatory back pain if 4 of the 5 parameters are fulfilled. This is an important paper published by Martin Rudwilite many years ago that looked at the likelihood ratios of various clinical features and how they fed into the overall diagnosis of ankylosing spondylitis. And you can see the likelihood ratios for the various components as listed in the left in the rectangles. Look how high the likelihood ratio is for HLA-B27 and MRI. And one can take these likelihood ratios and multiply them to get a likelihood ratio product. And anything above 83% is considered consistent with high probability with a diagnosis of ankylosing spondylitis. So, for example, if you look at the combination of inflammatory back pain, heel pain or enthesitis, and a positive HLA-B27, the likelihood product is 94.9%, which makes it highly likely that this patient has ankylosing spondylitis. Now, we're going to see shortly how these parameters were used to develop the new criteria for spondyloarthropathy, and that is shown on this slide. So in order to address the wide spectrum of patients with spondyloarthritis, the ASAS group developed new classification criteria, and these are outlined for the axial SPA group on this slide. So in patients with 3 or more months of back pain, an age at onset here is less than 45 years, as compared to 40 years for the inflammatory back pain we saw earlier, that one can make a diagnosis of axial SPA by one of 2 routes. On the left, patients have sacroiliitis on imaging, and you can see the double stars, meaning that they have active inflammation on MRI, highly suggestive of sacroiliitis associated with SPA, or definite radiographic sacroiliitis according to the modified New York criteria. So if they have either one of those features on imaging and one or more of the SPA features, which are listed below on the left, this is consistent with a diagnosis of axial SPA. Now, one can reach this diagnosis without imaging if you have a positive HLA-B27 in a patient, plus 2 or more of the other SPA features listed in the lower left-hand corner. So this is now being applied around the world to diagnose patients with axial spondyloarthropathy. And the major benefit from my perspective is that it now includes patients who don't have definite criteria according to the modified New York elements, and which requires radiographic changes, so that there are many patients who have a diagnosis of axial SPA that actually have pre-radiographic disease, and as you'll see later, these patients are just as likely to experience pain and problems with their disease as those that have radiographic abnormalities. So again, this is the new classification criteria for axial SPA. If you look down in the lower left-hand corner of this slide, you'll see a red address for a website. I highly encourage you to check out this website, where the ASAS group has a series of slides which you can download and use for your own education or to teach others. I think you'll find this slide collection is quite excellent and very informative. This next slide shows a whole body MRI, which we don't see very commonly in the United States. These are done in Europe predominantly. And the point I want to make from this slide is that involvement of the skeleton can be quite widespread. As you can see on the left panel, there's involvement of around the hip, insertion in the acetabulum, as well as enthesial structures at the arrowheads. And in the image on the right, you can see bilateral sacroiliac bone marrow edema, as well as corner edema in the 2 arrows up in the thoracic spine. So these kinds of MRIs show you the extent of disease in patients with axial or peripheral spondyloarthropathy and illustrate the osteitis and enthesial disease, which is so commonly seen in these patients. So the diagnostic assessment of AS includes a history of inflammatory back pain, and we've reviewed this quite extensively. One can use the BASDAI, which is a patient-centered questionnaire that has been shown to be highly validated for pain and in ankylosing spondylitis, and is sensitive to change. And so it's an important instrument that one can capture in the office and determine how your patient is doing at that time. Physical examination, the modified Schober score, 15 centimeters or less is considered to be low, although there's recent data that was presented at the ACR meeting that suggests the modified Schober score normal ranges may be lower than this. I want to see these data validated, but it may be that we'll be changing these numbers. Chest expansion usually considered 3 centimeters or less, and then lateral bending. C-reactive protein urinalysis, HLA-B27, can give us insight into inflammation and whether or not there's involvement of the GU tract, and obviously the association with of HLA-B27 with AS is very strong. AP pelvis and spine films. Sometimes one cannot get a good look at the SI joints with AP pelvic films, and some people do special views, although I don't think this is required on a routine basis. And then, as with our patient that I presented earlier, MRI can be performed in selected patients. So what about general practitioners? What role do they play in the identification of patients with inflammatory back pain? Well, based on the NHANES data set, which showed a prevalence of 0.9 to 1.4% of ankylosing spondylitis in the U.S. population, it's very apparent that many of these patients, if not a majority, are not making it to the rheumatology offices. So one approach has been to educate general practitioners in the elements that they need to screen for in patients who come in with back pain. And in this particular study presented in London at EULAR in 2012, 364 patients with chronic low back pain were identified from the general practitioner records. You can see the age and symptom duration. And they completed an inflammatory back pain questionnaire. history and physical examinations were performed by rheumatologists, and you can see the other studies that were obtained. 21% of these patients had axial SpA, and 6.6% had AS. Remember, AS is according to the New York modified criteria, which have to have radiographic abnormalities. And one can see the sensitivity and specificity of these four measures as shown in the table below. And it turns out that uveitis, enthesitis, dactylitis, psoriasis, and elevated C-reactive protein all had low sensitivity for the diagnosis of early AS. However, a combination of inflammatory back pain, family history of SpA, and response to NSAIDs were very predictive and high sensitivity, and these three components may help general practitioners to identify patients at risk for early ankylosing spondylitis. The other component that came out in this case history that we started with was that she had prominent chest wall pain and tenderness over the sternoclavicular joints and the costochondral joints as well. In this retrospective observational study of 275 patients, 37% of these patients with spondyloarthropathy had anterior wall chest pain, and the onset was in the first 5 years in the majority. They were often presenting with acute and painful flares, with nonsteroidals showing efficacy in about half the patients and TNF antagonists in 80% in this small series. They found that bone scan was more sensitive for subclinical involvement, but that MRI was preferable to detection of erosions, including the type and extent, as well as the presence or absence of new bone formation and bone marrow edema. These two studies have helped us to understand that anterior chest wall signs and symptoms are common in spinal arthropathy, occur early, and can improve with treatments that include both NSAIDs and TNF antagonists. Another important component when you have someone that comes into your office with ankylosing spondylitis who has chest pain is to ensure that they're not having cardiovascular problems or acute coronary syndrome. And there have been a number of studies that are starting to look at cardiovascular events in patients with ankylosing spondylitis, and this is one of them. This is again from the EULAR meeting in London from 2011. And here we're seeing cardiovascular disease prevalence, which was previously shown to be elevated in an AS cohort of 383 patients. And they took 286 patients from this cohort prospectively and followed them for 2 years. And you can see the mean age and the percentage of antihypertensive treatments, statins, and diabetes. And not unexpectedly, a large majority of these patients were taking NSAIDs, a small number of them anti-TNF agents. 4.4% of these patients had an incident cardiovascular event, and in 9 of these were first-ever events. And you're seeing how it breaks down, that these events were more common in males with AS and higher than in patients in the general population, whereas in women did not seem to be the case. So they showed that cardiovascular event rates were increased in the AS population. And this, along with other studies, which show that patients that are particularly high risk for acute coronary events are those that have high disease activity as measured by elevated acute phase reactants, baseline syndesmophytes, and high pain levels. And these patients we need to be concerned about and particularly vigilant regarding cardiovascular risk factors. The second question: which of the following risk factors is most strongly associated with severe radiographic sacroiliitis? A, disease duration. B, total hip arthroplasty. C, family history of ankylosing spondylitis. And D, smoking. The answer is on this slide. So this shows the risk factors for severe radiographic sacroiliitis in axial SpA. And you can see here the clinical associations of severe sacroiliitis in 151 patients. And the predictors are shown in the left side of the table, the odds ratios in the center column, and the p-value on the right. Now, all of these showed significant p-values, but clearly the presence of total hip arthroplasty had by far the greatest odds ratio of predicting which patients had severe radiographic sacroiliitis. Other factors, of course, shown here include the family history and non-Caucasian race. So these are the factors one needs to think about in terms of the association with severe changes in the SI joints in patients with AS. Smoking can also have an impact on early spondyloarthropathy, as shown in this series of 708 patients with inflammatory back pain of less than 2 years from the Desir cohort. You can see what criteria they met, and about a third of those were smokers. And if you look at the MRI findings in smokers and you look at the odds ratios compared to non-smokers, it's clear that they have a higher rate of spinal inflammation, SI inflammation, and structural changes both in the spine and the SI joint. They also had higher MSAS scores. Remember, those are a formal scoring of syndesmophytes in the axial spine. Earlier inflammatory back pain, higher ASDAS and BASDAI scores, which are used to score the activity of ankylosing spondylitis, a higher BASFI, and worse health-related quality of life. So clearly, early disease is impacted by smoking, which has the potential to be both a prognostic factor and a possible pathogenic factor, but of course, the association in terms of etiology has not been established. But we need to be counseling our patients with early axial SPA that they should stop smoking if at all possible. We also know that AS can limit function, family life, and productivity, as shown on these studies by Dr. Ward. Patients are less functional in their jobs with repeated stretching, bending, twisted, or reaching. Whole body vibration is associated with more radiographic damage. And these patients are more likely to have never been married, divorced, and more than twice as likely to be work disabled than the general population. And recall that our young patient who I presented at the beginning of this virtual grand rounds was someone who was looking for a work disability from her position on the assembly line. And then lastly, women with AS are less likely to have children than the general population. And clearly there are certain features that are common to women who have AS, which I'll be touching on shortly. So what about pre-radiographic versus radiographic AS? Well, the clinical manifestations and disease activity in these two groups are highly comparable. Male sex and increased CRP are associated with increased structural damage, and HLA-B27 is associated with earlier disease onset. And both adalimumab and infliximab show good clinical efficacy and safety in patients with pre-radiographic AS. So there is now an emerging thought that patients who have either, you can call it non-radiographic versus pre-radiographic, because, of course, pre-radiographic presumes that they're going to develop X-ray changes, and many will not, versus radiographic, and that these two groups clinically and in terms of the impact of the disease on their function in life are very similar. What about ankylosing spondylitis in females? We know that the male-to-female ratio is in favor of men, although how strongly in favor of men is somewhat of a controversy. We know that this disease, like in males, is underdiagnosed, but maybe even more underdiagnosed in women. We know that these patients are more likely to have cervical spine involvement and peripheral joint pain than males, and less radiographic damage. Nonetheless, they often have more functional limitation despite the lower degree of radiographic damage. So AS in females can be difficult to diagnose, but this is a group that there really is a major unmet need in the field. So our second case is a case of fever in an ankylosing spondylitis patient. A 28-year-old male with AS diagnosed 3 years ago presents with fever and weight loss. Fevers have not exceeded 102 degrees and no sweats, and began 2 weeks ago while he was on vacation in the U.S. He has been on etanercept 25 milligrams twice weekly since diagnosis, and the back pain has been in remission since that time. He underwent a right total hip replacement. Remember from earlier in this presentation, I mentioned that total hip replacement or total joint replacement is a marker for more severe sacroiliitis. And he had this shortly after diagnosis, and the prosthetic hip was functioning well. He denies cough, abdominal pain, adenopathy, hip pain, or rash. He did travel to Russia with his wife 6 months earlier, but the trip was uneventful, and he felt well when he came home. He has no remarkable past medical history. He had the hip replacement several years ago. He's recently married, non-smoker, and works as a computer programmer. The family history is, as you can see, there is no history of spondyloarthritis, psoriasis, uveitis, or Crohn's disease. And on review of symptoms, he had severe fatigue, but no shortness of breath, peripheral joint pain, or nausea. His appetite had decreased, but he was not anorexic. On examination, he appears chronically ill. He actually lost about 4 pounds when I saw him since the previous visit 4 months earlier. He was slightly febrile, normal blood pressure, pulse slightly elevated, and breathing well. Dry mucous membranes without lesions. The neck was supple without JVD or thyromegaly. Excuse me. His chest was clear. Heart exam normal. He had a slight degree of right lower quadrant tenderness to deep palpation, but no masses or rebound. And there was no cyanosis, clubbing, or edema in the lower extremities. His musculoskeletal examination was totally normal in the peripheral joints, but he had a Schober score of 12 centimeters. His prosthetic hip had good range of motion and no pain and manipulation. And his neural exam was totally normal. Hematocrit was 34 with a low MCV, and iron and ferritin were also low. SED rate was 65 with a CRP of 78, and the remainder of the chemistry profile was normal. Blood cultures were negative. His procalcitonin level was in the normal range, which lessened the likelihood of infection. Negative PPD with a clear chest X-ray. Flat plate of the abdomen was normal, but he had a positive stool guaiac. Because of these findings, he had a colonoscopy, and findings were consistent with Crohn's disease in the distal ileum and proximal colon. So here we have a young man who was presented with very active ankylosing spondylitis and markers of a more severe disease course with severe hip disease at a young age, who did well on etanercept for several years, but then presents with fevers and weight loss, slight abdominal pain, and is found to have Crohn's disease. So I'm going to now talk about factors to consider in the treatment of spondyloarthropathy. I'm going to come back to our case when I talk about the comorbidities that we see with ankylosing spondylitis, and then conclude with some comments on therapy for these patients. So in the treatment considerations, one has to remember that these patients can have both axial and peripheral joint involvement. Our patient was limited to the axial spine except for including the hip from earlier. They can have enthesitis and dactylitis, very much like psoriatic arthritis. Their bone phenotype can include both bone resorption and new bone formation. One can predominate in a patient, or there can be a mixture of phenotypes. There's less reliance on change in acute phase reactants to assess response, because often the acute phase reactants in these patients, even with fairly active disease, may not be elevated. And then there's unique extra-articular features when thinking about a common form of inflammatory arthritis, rheumatoid arthritis, and these include uveitis, inflammatory bowel disease, and psoriasis. And as mentioned earlier, genetic associations are with MHC class I alleles, but also with IL-23 receptor, which supports a pathogenesis that is quite distinct from that we see in rheumatoid arthritis. Rheumatoid arthritis, of course, being a prototypical autoimmune disease with a very clear autoantigen citrullonated proteins and a specific and autoantibodies that are associated with this disease, the anti-citrullonated polypeptide antibodies. So the treatment of ankylosing spondylitis has been shown in this algorithm developed many years ago by Jane Zockling, beginning with education, exercise, PT, rehabilitation, self-help groups, and non-steroidal anti-inflammatory drugs in the first line, For patients that have peripheral disease, one could add izolfidine or other DMARDs, sometimes local corticosteroids to inject. But those that have axial disease who fail both the NSAIDs and all of those in the blue box to the left really vault ahead to anti-TNF agents because DMARDs have not shown to be effective for treatment of the axial skeleton. So it's important to emphasize that non-steroidal anti-inflammatory drugs have been used in this disease since 1949. Generally, patients are on these drugs over a long period of time and without a break. And controlled trials have shown good or very good symptomatic relief in a large number of patients. Most trials have been in patients with more advanced disease or radiographic AS. And an enduring question that has not until recently not been formally addressed has been whether or not these agents are actually disease modifiers. And I'm going to touch on that in a moment. Side effects have been emphasized in these drugs over the last several years, particularly after the experience with Vioxx and cardiovascular events. So looking at meta-analysis, the risk of a major cardiovascular event, it seems to be quite low in naproxen, somewhat higher in the non-selective agents and in the COX-2 inhibitors. There's also, as we know, an increased risk of major GI adverse events that are increased significantly, more so in the non-selective than in the COX-2 agents. Those patients who have are particularly high risk and where proton pump inhibitors should be considered are patients with more than 60 and who have the following risk factors: history of ulcers, on low-dose aspirin, smokers, using steroids, or are on 2 or more NSAIDs, although certainly in our practice we strongly counsel patients not to take more than 1 NSAID. And we can see that the PPIs can decrease the risk of a GI bleed considerably, and other considerations to take into account, including LFT elevations, small bowel ulcerations, edema, hypertension, and renal failure, all of which can be brought on in some patients who are on non-steroidal anti-inflammatory medications. So these drugs are highly effective, but again, continuous use is required. Serious adverse events occur at about 1% per year, and it's important to monitor urinalysis, LFTs, creatinine, and blood pressure the first month, and then every 3 to 6 months thereafter. And then the choice of a selective NSAID, COX-2 inhibitor, for example, is based on the patient's risk profile and according to its efficacy. And we all know that predicting efficacy of a non-steroidal anti-inflammatory in a specific patient is really very difficult, and one has to really do this empirically, and it's amazing how some patients can respond very well to one non-steroidal anti-inflammatory and have absolutely no response to another. Physical therapy is a cornerstone therapy in ankylosing spondylitis with emphasis on proper posture, home exercises. Even formal physical therapy can be very beneficial for some patients. And, of course, water exercises, in some cases, inpatient rehabilitation can be a very important and much-needed intervention. So I show this slide which emphasizes the various components and pathophysiologic factors that are essential in the development of ankylosing spondylitis. So these include both genetic factors and axial myofascial tonicity, immunobiology related to genetic factors, and mechanobiology related to the tonicity factors, and then a variety of interactions at the extracellular matrix, gene activation, cellular proliferation, apoptosis, and necrosis, and then inflammation. And whether or not inflammation directly leads to osteoproliferation is a matter of debate, which was debated very eloquently in arthritis and rheumatism in, I think it was the March or April 2012 issue. But I show this slide to just remind ourselves that it's not only the immunobiology that we need to focus on with our anti-TNF agents and other biologics, but also the mechanics of the patient, which really often can respond to physiotherapy and attention to proper biomechanics with footwear and the like. We know that anti-TNF agents are effective in AS, and there's 4 phase 3 trials. It's important to note that all these subjects met the New York criteria for AS, and that patients experienced short-term improvement in pain, function, and decline in inflammatory parameters. And you can see that there was improvement in all the measures shown here that are typically obtained in patients with AS, and also an improvement in bone marrow edema on MRI. Now, there are also studies I did not review here, or will not review, that looked at the efficacy of adalimumab and infliximab, and more recently certolizumab, in patients with non-radiographic SPA, and have shown that these agents are highly effective compared to placebo as well. These MRIs show the changes one can see in the thoracic and lumbar spine in ankylosing spondylitis, the T1 weighted images shown in the far left with the arrows pointing out to the regions where there's increased signal. Then you can see post-gadolinium, and again, bone marrow edema, largely at the vertebral end plates and where the entheses insert. And then the STIR images are shown on the right. The thin arrows are showing fatty degeneration, and the bold arrows, so-called chronic inflammatory lesions, are the inflammatory spinal lesions. It's been shown in this small series that most patients have persistent inflammation, even despite treatment with anti-TNF agents, in this case infliximab. And they obtained MRIs at baseline 2 and 12 months, and they used diffusion-weighted imaging and a variety of other ways of trying to interpret these images. And using these approaches, a very small minority showed no inflammation at 12 months, despite the fact that they felt considerably better. So that residual inflammation, which was undetected in terms of by examining or questioning a patient, could be responsible for structural progression in patients on anti-TNF agents. This slide from the ASSERT trial, and comparing it to the OASIS study, which was a cohort of patients who had AS but were not treated with non-steroidal anti-TNF agents, shows that treatment of patients with infliximab did not decrease radiographic progression in ankylosing spondylitis. Now, as shown on the y-axis, this progression is measured as the MSAS score over 2 years, and this is a score that looks at the number of bony syndesmophytes. So despite the fact that these patients often feel better on anti-TNF agents, it does appear that their X-ray progression, as measured by new syndesmophyte formation, does not decrease. Now, in this slide, I outline the vertebral changes that one can see in spinal arthropathy and how these might be influenced by various treatments. So these chronic corner inflammatory lesions shown on the left in gray, I showed you evidence of those on the MRI. But it appears that in some patients who receive anti-TNF agents, there appears to be a transformation, if you will, of these chronic inflammatory lesions to fatty lesions. Now, not all the patients develop these fatty lesions treated with anti-TNF agents. Some of the lesions completely resolve. And then, with time, these fatty lesions, it's thought, although this has not been proven, but this is one model, can undergo change to either syndesmophyte or completely resolve. And that non-steroidal anti-inflammatory medications may have the ability to decrease the transition from this fatty to bone syndesmophyte lesion. Although, again, that remains to be proven, but I'm going to show you some data shortly that support the idea that non-steroidal anti-inflammatory medications, particularly when combined with anti-TNF agents, may be able to slow down the syndesmophyte formation. It's important to point out that X-ray progression in ankylosing spondylitis is nonlinear, and here we see disease duration in a variety of different patients, and on the x-axis and on the y-axis is the MSAS score. And note the high variability from patient to patient in the progression of the MSAS score, with some patients progressing very rapidly over a short period of time and other patients remaining relatively stable. So this emphasizes the need for a personalized approach to the treatment of this disease. Unfortunately, we lack markers which will tell us which patients are more likely to have the very high slope of progression and those that progress very little at all. I know that there's a lot of very fine work underway to try and identify these biomarkers, and we certainly look forward to the day when we have these kinds of markers that can help us predict this bone formation response. So these data show that nonsteroidals may inhibit radiographic spinal progression in axial SpA. So on the left, you see the MSAS change on the y-axis, and they're looking at two groups of patients, those that have risk factors for progression on the left and those that have no risk factors, and they're comparing low NSAID intake to high NSAID intake. And one can see very readily that those patients who have baseline risk factors for spinal progression and have high NSAID intake have a lesser degree of syndesmophyte formation over time than patients that have the risk factors and had low NSAID intake. If patients had no risk factors for progression, no baseline syndesmophytes or elevated CRP, then low or high NSAID intake did not seem to have a significant influence on MSAS change. And these data would suggest that those where we should consider the addition of nonsteroidal anti-inflammatory medications are those patients that indeed have these risk factors for progression. This slide shows a percentage of patients who have extra-articular manifestations in the ankylosing spondylitis group, and we can see that 42% of these patients at some time had an extra-articular manifestation, most of these being anterior uveitis, followed by psoriasis, inflammatory bowel disease, and a combination. So this is obviously something we need to really be cognizant of. And I already mentioned earlier that cardiovascular disease may be an issue, particularly in patients with ongoing chronic active disease. So let's get back to our case. This patient was diagnosed with ankylosing spondylitis, treated with Enbrel, did very well, and then presented with fever, abdominal pain, and weight loss. Well, we know that Crohn's disease is associated with AS, but what precisely is the prevalence? So this is from the Olmsted County database at the Mayo Clinic in patients with Crohn's disease, and they followed them up until death. So this is not looking at SpA patients, but looking at Crohn's disease patients. And they found that over time, the cumulative incidence of SpA went from 1.4% in patients with Crohn's disease to 10% at 30 years. So their conclusion was that in patients who have Crohn's disease, that one has to be aware and cognizant of the possibility of an associated spinal arthropathy, and that this incidence can rise dramatically depending on the duration of the Crohn's disease. So in our third question, which of the statements regarding the prevalence of asymptomatic gut inflammation in peripheral SpA, non-radiographic SpA, and AS is most accurate? A, axial but not peripheral SpA is associated with asymptomatic gut inflammation. B, the prevalence of acute and chronic asymptomatic gut inflammation is similar in non-radiographic SpA and AS. C, chronic asymptomatic gut inflammation is more common in non-radiographic SpA than AS. And lastly, D, acute asymptomatic gut inflammation is most common in peripheral SpA. The answer is shown in this slide. So in this study, the investigators asked, is the prevalence of gut inflammation different in non-radiographic axial SpA versus AS? And they did ileocolonoscopy on 58 patients, all TNF antagonist naive, who had no GI symptoms. And you can see the symptom duration, age, and HLA-B27 status. And perhaps what's most remarkable in these three groups of patients is that all of them had acute and chronic inflammation. Patients with AS were more likely to have a chronic inflammation. Those with non-radiographic SPA were more likely to have about equal amounts of acute and chronic inflammation, whereas patients with peripheral SPA had lower numbers of both, but certainly a significant percentage of patients had both acute and chronic changes in the GI tract. So these studies tell us that gut inflammation is important in all these groups of patients with spondyloarthritis, and we have to keep this in mind. A critical question which remains to be answered is whether or not this gut inflammation may be a key generator of inflammation in the axial and peripheral skeleton. Studies in the microbiome in these patients will help to answer this important question. So we're going to come back to our patient. He was started on infliximab for the Crohn's disease, 5 milligrams per kilogram every 8 weeks, and his Crohn's disease went into remission. His joint disease also continued to do well. He did well with this for about 4 years, but the bowel symptoms recurred between infusions. The intervals were shortened of the treatment, and methotrexate was added, but both his low back pain and colitis remained active. Colonoscopy showed recurrent colitis. What is your next step? Well, several years ago, I wrote a paper which talked about the role of the treatment of TNF refractory ankylosing spondylitis. And I think the first point to consider in these patients is not only consideration of addition of other medications, such as non-steroidal anti-inflammatory medications. Of course, in our patient, that would be a problem since they have Crohn's disease. But consider intra-articular injections into the SI joints or other joints, physiotherapy, analgesics, gabapentin. It's important to make sure that their pain is not mechanical back pain, because these patients can have mechanical back pain just like any other patient, and sometimes that's the key factor and not their ankylosing spondylitis. This can be very hard to tease out, but obviously critical components from the history exam and sometimes imaging can help to pick between the two entities. Disease-modifying anti-rheumatic agents are useful for peripheral arthritis, but not for axial disease. And of course, there's been a lot of work now done on antidepressants and helping to modulate chronic pain. For those of patients who fail an anti-TNF agent and their TNF agents are not contraindicated, either because of some side effect related to TNF blockade, one can switch to another TNF or increase the dose or decrease the interval, and we're all very familiar with that. If anti-TNF agents are a total failure in a patient, we don't have a lot of options, but one can think of thalidomide or IV pamidronate. There's very limited data for the efficacy of either of these approaches. And I'm going to talk about another approach in a moment. For those where TNF is contraindicated, again, thalidomide or IV pamidronate are really much less than desirable alternatives because the response rates in small studies are quite low. So what other option do we have? Well, interestingly, ustekinumab has been studied in ankylosing spondylitis. As you know, this is an anti-P40 antibody which binds to both IL-23 and IL-12. And so this is a study published recently in the New England Journal of Medicine looking at the efficacy of this drug in Crohn's disease. And on the left, you can see the efficacy in terms of inducing a clinical response and a clinical remission, with the white being placebo and then the different doses of ustekinumab in the colors to the right. And then if you glance to the right, one can see the ability of ustekinumab to induce maintenance in patients with Crohn's disease. I only show you these data in order to say that in our patient that we presented here, that ustekinumab can act to inhibit active inflammation in the colon in patients with Crohn's disease. Well, what do we know about ustekinumab and ankylosing spondylitis? Well, not much. However, we do know that another drug which blocks the IL-17 pathway called secukinumab showed great efficacy in AS in a small, short trial of 6 weeks. And here one can see the percentage of patients that achieve the ASAS-20, 40, and the ASAS-5-6 with a mean decrease in the BASDAI score of minus 1.8. So in this patient, I think a consideration would be, if he cannot tolerate an anti-TNF agent for whatever reason, that ustekinumab could be a reasonable alternative to treat his bowel disease, and there is the possibility that the pain in the axial skeleton would improve as well, although it certainly needs to be tested formally in a clinical trial. So what are the future therapeutics in AS? A great unmet need. Identify patients with early disease. Perhaps if we get them early enough, treatment with agents such as anti-TNF medications may be enough to prevent this subsequent new bone formation, although that remains to be determined. Obviously, better understanding of the mechanisms that lead to new bone formation and maybe independent of erosions is critical, and there are advances being made in the basic science of this disease, particularly in looking at interleukin-23 and interleukin-22, bone morphogenetic proteins, as well as molecules in the Wnt signaling pathway and the hedgehog pathway, all of which may be critical in the generation of the bone formation phenotype that we see in spondyloarthropathy. Importantly, restoring balance between DKK1 and the Wnt signaling pathway, DKK1 being a molecule that inhibits Wnt signaling, is something that should be considered, and people are looking at these molecules as well. I've talked to you about ustekinumab and secukinumab. I know we're going to be seeing additional data with those agents. I think it's important to note, however, that antibodies to interleukin-6, rituximab, and abatacept have shown to be not effective in AS. And so here we see a very big difference between the efficacy of therapies for RA and in spondyloarthritis. So in summary, inflammatory back disease is prevalent and often undiagnosed according to recent data. New diagnostic criteria should help identify patients with early non-radiographic inflammatory back pain, and these patients often fare as poorly as those who have X-ray changes and can respond to therapy with anti-TNF treatments. Anti-TNF agents are effective for relief of pain, but may not block structural progression. And lastly, novel therapeutic options are available for treatment of spondyloarthropathy. I think we're going to be seeing additional trials with these agents in the coming years, and hopefully someday a portion of these will make it to the clinic and help us to greatly relieve the pain, inflammation, and structural changes that are faced by our patients with spondyloarthropathy on a daily basis. This concludes the virtual Grand Rounds on spondyloarthropathy, and I thank you for your attention, and have a great day.
Thanks, Chris. That was really terrific. You know, the things that I am taking away from your presentation from my practice in particular is the notion of non-radiographic axial spondy. I've been seeing an increasing number of patients who have presented with atypical manifestations without any evidence of sacroiliitis, and this is with or without MR imaging. I recently saw a 45-year-old anesthesiologist from Oklahoma who was debilitated, who had kind of a PMR picture, but it was widespread enthesitis that could be easily seen by MR. But the sacroiliac joints were pristine, and there is a strong family history. I've also seen several similar cases, and the response to TNF inhibitors are so gratifying. You know, I think in addition, we now understand that spondyloarthropathy has comorbidities not dissimilar from rheumatoid arthritis and psoriatic arthritis, and thus we as rheumatologists have to step up with immunization practices as well as cardiovascular risk reduction, etc. Finally, we have a fine armamentarium of therapies right now, but it's getting even better. And I think that what we'll be seeing with the IL-22, IL-23 pathway will, I think, show some great promise in the years ahead. So thanks again for Rheumatology Grand Rounds. I'd like you to come back. We have a lot of other cases and many more to come. Thank you.